All right, we should be recording. Well, welcome everybody. I'm David Stahl. I'm an associate clinical professor and the residency program director at The Ohio State University. And I'm really excited to be here virtually with Dr. Glenn Woodward, who many of our audience know as the executive director of the Anesthesia Toolbox, but of course, who is also a professor and the director of the Regional Anesthesia and Acute Pain Medicine Fellowship at Oregon Health Sciences University. Dr. Woodward, thank you for being here.
Thanks so much, David. I really appreciate you you having me. And we'll be casual, Glenn and David, as opposed to doctor and doctor this morning.
All right, sounds good. Well, I think while many of us in graduate medical education are throwing up our hands in exasperation about trying to figure out how to run a training program during a pandemic, you've been busy thinking about how to improve the feedback we give our trainees. So tell me a little bit about what was the problem you were trying to solve when you started this?
Well, I had really two things that have been jangling around in my brain for quite some time. One was the difficulty that programs have with the milestones. We have to report the milestones to the ACGME, but it's fairly challenging actually to fill them out with really some data to support it. I mean, really, we can fill them out by just making it up, just checking the boxes and things. But do we have any objective information that helps us inform what we are filling out on those? And I think that's been a big challenge for a lot of programs. The second thing that I always find interesting is, so programs have tried to solve that problem. And a very common one is that they will send you out some sort of evaluation that you have to fill out. You might have a daily evaluation that you're supposed to fill out on residents. You might be supposed to fill out an evaluation when you work with residents. But it turns out, and unfortunately, faculty are pretty bad about filling out those evaluations. They're typically not timely, so that means that they're often filled out at some delay after that they work with the resident, which means that the information may not be as accurate. Most of the faculty would sort of admit that. If I haven't worked you for a week, that was a lot of patience between now and then, and I don't even remember what happened. So they tend to not be very timely. The second is they tend not to be meaningful to the faculty so that they sort of embrace the evaluation. They think it's just something they have to do and a requirement, and they just sort of do it, and their heart and soul necessarily isn't into it. Not that I'm going to be able to get their heart and soul into it either. But because they don't really think it's very meaningful, I don't think that the information that we get back on those evaluations is as good as we'd like it to be. The second thing is because the faculty aren't really thrilled about filling out evaluations, they don't fill out very many, which means if you only have a few evaluations for a resident, then a bad evaluation is going to stick out a lot more than if you had 100 good evaluations and one bad evaluation. It wouldn't be the same thing. So that's another issue, is we don't get a lot of information. Instead, we just get a little bit, which could overly bias or skew the view of a resident. So those are the kinds of things that I've been worrying about. And, I wondered if there was any way that we could try to address that.
Well, that's a big thing to take on, to think about. What I'm hearing is we want to fill out the milestones. We want to have real data rather than just our gestalt about each resident. And we'd like to have that data come from the faculty who are directly working with the residents. But oftentimes our way of doing that and giving an evaluation is neither loved by the faculty nor really used to its best potential. So when you were starting this project, what were your goals to kind of start from the beginning?
Well, first of all, this is probably a relatively universal experience that I think most programs and faculty struggle with. So, that was really an important thing. So there have been a lot of stuff in the literature about these things called workplace-based assessments. Our goal was to try and address the things that I had discussed earlier about faculty disenchantment with the evaluation process, not filing enough, not timely, and trying to give meaningful data. So that was really what our goals were. But one of the ways that we wanted to tackle this was a thing called workplace-based assessments. And so this was a way of tying the assessments more specifically to things that we do every day with the residents, as opposed to having some sort of abstract evaluation come to me in the email that I just fill out that may not have any or much relevance to the patient that I just worked with or the case that I just worked with the trainee. So that is where we began our focus. There have been a lot of work being done on this thing called entrustable professional activities. And an entrustable professional activity is a type of workplace-based assessment. And so an example in anesthesiology is, I'm going to do a labor epidural. I'm going to take care of a laboring patient with you, and we're going to provide analgesia. That's something that you and I are very familiar with. That's definitely a task-oriented type of thing that the resident would need to do, and evaluating them on how well they are able to do that seems to make a lot of sense to me as a faculty member. And that was the basis behind workplace-based assessments, in particular, these things called entrustable professional activities. We'll call them EPAs for short.
Okay.
So
when go ahead.
They're designed to be a type of workplace-based assessment around things that we normally do with the resident.
Got it. So the idea is within the realm of kind of workplace-based assessments to use EPAs as kind of your yardstick to measure how residents are doing. How do you get faculty and residents to kind of buy into a new system from the beginning, so it's not just another thing that they have to do?
Yeah, that is a whole conversation really in itself, because trying to do anything as large as that within a residency program is really culture change. Right. So you have an embedded way in which I'm sure your program does evaluations now. And even though the faculty hate it, the minute you tell them that you're going to do something, and the residents too may dislike it strongly.
Right.
And the next thing that you're going to do is, we're going to fix it. We're here to help. Well, that comment is usually met with a lot of skepticism. So anything that you're going to do that's going to be a big change in this area is probably the biggest hurdle that you're going to face, is how you're actually going to do the culture change and implementation to get buy-in from the faculty. So it wasn't something unique to what we were trying to do. It was just trying to change our department's outlook on how we do assessments, and that was a big challenge.
Yeah, it's been a learning experience for me as a program director to realize that the best, greatest idea doesn't matter if you don't have all the people on board who also matter. So I can imagine that was a challenge.
Yes,
how
definitely.
How did you get the project off the ground? Like, what was the starting point?
Well, first of all, we had a little bit of a benefit. You know, we're not here to recreate the wheel. That's never been one of my things. I want to try and take advantage of best practices around. And fortunately, there were European residency training programs, Canadian and Australian, that had already been working with EPAs. So they'd done a lot of work to define what they thought were the key workplace-based assessments that we should use in anesthesiology training. So I joined an international group that was responsible for discussing those and developing them. And I was able to get pretty good insight about what they were doing and where they were having problems. You know, how they were revising their EPAs based on what they were doing. The second thing is that EPAs were actually coming out in medical schools at the same time. The medical schools are deploying EPAs now for almost across the country. So we could get some advantages of what they were doing, the process they used to develop them, the definitions, how were they defining them. So we basically took that work as our starting point to say, okay, we can start with what other people are doing. We have a structure. We know what they kind of look like. How should we change them or tweak them for U.S. anesthesiology training? Because we're a little bit different than the Canadian system, for example. And also, how can we change them based on feedback that the other programs have already gotten about deploying their EPAs? So, for example, one of the international systems had 70 different workplace-based assessments. And you know, part of the feedback they got is the complexity around having 70 different types of evaluations. And so as a part of the get-go, we decided, okay, we're going to try and come up with some sort of a list that's going to be simpler than that. So our goal was, can we create an assessment system that is simple, that you could fill out in just a couple of minutes, and would be very straightforward, and you would not need any training to be able to do it. That's another thing, right? Because if it requires any training, pretty much nobody's going to do it. So that's how we got the project off the ground, is by starting out with some of the international EPAs in anesthesiology. We put together a group of education researchers and program directors. So I think about 16 or 17 people in the group. We solicited the ABA and the RRC to see if they wanted to be involved in this process, but neither of those groups had anything going on in EPAs, and just said, well, just let us know what you're doing, but they didn't actually contribute any resources or people to the project. So we just sent out an email to a list of program directors that we had and said, hey, send us any PDs, associate PDs, or education researchers, or people that have anything specialty in EPAs in your department that want to participate in this project in trying to come up with a new EPA system for anesthesiology training. So that's how we started out. We ended up with about 17 people, representative across 11 different programs. So it was a reasonably mixed group, small programs, large programs, East, West, Midwest. So I thought that was a good way to kind of get started.
You've kind of, I think, done a great job of explaining what an EPA is. And you mentioned that, for example, placing an epidural for labor analgesia might be an EPA. Could you give us some other examples of EPAs that are specific to anesthesiology?
Yeah, so I'll kind of tell you what we ended up with. So we started out with the 70 international EPAs that had been developed for the Canadian system. We added in a few from some other programs. So we said, here's a starting list. We went through a Delphi process with the committee and asked them to revise that list, to add things to it or delete things to it. But we did give them the instruction that we want to get down to something, a much more manageable size of number of EPAs. And we didn't know what that number was, but we said, it's probably going to be something less than 30. So we went through several rounds of a process of people voting up and down on which things that we should do and how we should title them. And we ended up with a list of 20 EPAs. And if I can share my screen, I actually have that list. So I'm going to just pop it in here. And I'm going to put this up. And you might not be able to see it very well, but this is the list of 20 EPAs that the group came up with. There were 5 foundational EPAs. So a preoperative assessment, perioperative airway management, PACU management, and transfer of care. And we also called perioperative care of a general operating room case as sort of a foundational skill. And then there were essentially subspecialty tasks. So taking care of a laboring patient, so providing labor analgesia, perioperative care for a C-section, perioperative care of a pregnant patient undergoing non-obstetric surgery. And then there was a couple of pediatric ones, cardiothoracic, critical care, and chronic pain, those kinds of stuff. So that was kind of the list of EPAs that we started with, and I'll hand the football back to you.
I think, just looking at that list, it is neat to see that you mentioned that EPAs shouldn't require training to kind of assess them. And I think that when I think about the milestones, anytime I want somebody to evaluate a resident on milestones, I feel like I need an hour lecture and several handouts to get them to understand it. But for those who really maybe aren't familiar with the milestones, how do you compare kind of milestones and EPAs, and what similarities or differences would you draw between them?
Yeah, that's a great question. So the first thing I was going to go back on, I'm going to kind of readdress one thing you said at the beginning about the training and understanding. So EPAs are organized around the principle that it should be some familiar work-based task that we know about, right? And so that should be really easy to me to understand. I'm going to be evaluating you on how well you take care of this thoracotomy. Okay, that makes sense to you and I. The second thing is how I'm going to evaluate you. And the assessment is the concept of trust, which is why they're called entrustable professional activities. Because it ties right into how we think about trainees. How much do I trust you to do that case or that thing? Right. Do I trust you to do it when I'm out of the room? Do I trust you to do it on my family member? How much do I trust you? So those are the two principles of EPAs. It's got to be very meaningful to me, and the trust relationship is how I'm going to do the assessment. So that's one thing that makes it a little bit different from milestones. The next thing is milestones are really what they are is they're organized around very specific competencies. Very specific things that you are able to do. You are able to take care, you'll be able to do a preoperative assessment in this way and know this thing. Your medical knowledge, you have to have scored something on a certain set of tests to be able to achieve a milestone within the competency of medical knowledge. So I kind of think of it as like a car. And if you break down a car, there's a lot of different pieces in there. There is a gas pedal. Of course, maybe you've got an electric car now, but there's a gas pedal, there's a thing to roll up your window, there's a rear view mirror, there's a tire, there's an alternator. But an EPA is more of a holistic view of that car as, can you drive that car to A or B whereas milestones are more specifically, is your left taillight out? So I think that's kind of one way that I make the contrast is granularity, is that the milestones are very specific on these competencies. And that's what makes it difficult for us to evaluate. What do we do with if your left taillight's out, but we still know you're able to drive that car and get from A to B? What do we do with that information? So I think that's one way that I characterize them, is a little bit on their granularity and what they're trying to assess.
Yeah, I think that's neat. One other analogy that I've heard is it relates back to parenting, but I can know whether or not my kid can reliably tie their shoes. But what I really want to know is, like, can they get all the stuff together that they need to get in the car so we can go to school in the morning? And right. The competency is tying the shoes, but the entrustable practical activity is, can they get to the car with all the things we need to go where we're going to go? And in many ways, that the second part matters more to all of us in our functional lives.
Yeah, so in our assessment system, we decided to assess the EPAs. So can you do that thoracotomy or that laboring analgesia? And similarly, we also had procedural skills. So we broke out things like, it seems to make sense that everyone would agree that placement of an arterial line is a core skill of a graduating anesthesiologist, something we should all know how to do. But pretty much everyone would also agree that we have no objective evidence whatsoever that says that a graduating resident is competent in placing an A-line. Something as simple as that. So we also rolled into this system a bunch of procedural skills, and we're going to use the same evaluation system and trust for evaluating procedural skills. A lot of the other EPAs in other areas bake any procedure into the workplace-based task. So in other words, to do a thoracotomy, you should be able to place a double lumen tube. You should be able to do an A-line. You should be able to do a thoracic epidural. All of those things are encompassed in the EPA for a thoracotomy. But anesthesiology is so heavily procedurally oriented. We also broke them out, and we offered a way that you could evaluate those. But how do they tie to the milestones? How do you tie the EPAs to the milestones? Right. So what we wanted to do was inform the milestones. So we took the EPAs, and based on your performance, the level of trust that you were granted for that EPA, we looked back at all the milestones and said which milestones would be reasonable to award you based on your level of trust that you got for that EPA. So you get more milestones awarded if you are independent practice level of trust for an EPA than if you are where you needed frequent consultation with me. So that's how we tried to tie each one of our EPAs back to the milestones.
Got it. What does the scale of entrustment end up looking like practically for your faculty? From, I have to do this for you, to you can do this on your own, or where is the upper limit as well?
Right. So there's been a lot of work. There's been several papers published on the different entrustment scales. There's very little data that's necessarily validated how to do them, but we basically settled on a modification of one of the entrustment scales. And I'm going to just pull it up on here, and I'm going to share my screen again. You might not be able to see this, but I will share it to see if it works. Right here, and I'm going to do share. So this is actually what it looks like on the app, if you can see this. So I actually took a screenshot of the app. These are the 5 levels of entrustment. The top level is I did the activity. So just yesterday, I was working with a brand new CA1. They'd never seen or done a spinal before, and essentially I did it. I had them get in there and do a few little things, but pretty much I did the activity. The top level is independent practice. So we have 5-level scale. I completely trust you to do this on your own. I don't have to be here. You could be doing this out in private practice on your own. So in between are a few levels. The next level up from I did it is direct supervision, and I call it the resident whisperer. They're doing the activity, but I'm kind of right there, and I have to say, okay, now we need to do this. Now we need to put the needle here. Now we need to do that. And I think that's kind of direct supervision. I'm there the entire time and essentially directing the procedure. So the only two that might anybody have any, what are these things? Everybody would understand I did it, direct supervision, and independent practice. So the only two that have any, not controversy, but that you'd have to understand is these two. So reactive supervision and available if needed. And the only difference between them is the amount of consultation that the trainee needs. In both circumstances, I could leave the room and they could do stuff, and I could leave the room for extended periods of time and trust them to continue on with the task. But in reactive supervision, they're going to be frequently consulting me. Either it's by telephone or ask me to come in and just take a look at something, or what do you think I should do next? Or their blood pressure is up and I was thinking of starting this. Is that a good idea? You know, that would be frequent consultation, and that's reactive supervision. I'm reacting to what they're asking me to do. Available if needed, that's rare consultation. They're pretty much on cruising on their own. You know, they may have to ask me a couple of things here and there. That would be available if needed. So that's the kind of entrustment scale that we've decided to use in our system.
That's really neat. So practically speaking, if I'm working with a resident tomorrow in the operating room, how do I then give them this feedback or evaluate them on the EPA scale?
Yeah, so one of the other principles that we wanted to work with is, you know, obviously we actually did spend a little bit of time developing an app that you could use on your phone to do this. And my brother actually was a senior developer for Apple. So he developed you know, an app that we could use on a phone, you know, but we needed a lot more than that, right? We needed an app that everybody could use to simply fill out the evaluations, but we needed a database to store all that information in. We needed reporting so that the program director or the CCC could have reports, or the resident could have reports. There was a lot more to that system. And we didn't want to try and develop all of that, spend the money and try and commercialize it. So what we did was we went around looking around in the market to see who had something that was pretty close to what we wanted to do, or something that we felt we could build off. So we identified a company that already had some technology and that was playing around with EPAs in another field. And so we contacted them and said, hey, can we work with you? We will be responsible for developing all the assessments and the evaluations. And then we're going to tell you what we sort of want to see in the app and then the reporting, and they would help develop it all. But of course they own it, and they can go sell it to, you know, whoever they want to, but we would end up with this end product that everybody could use. So right out of the box, any program could just simply turn on the system and use it. So we partnered with a company to do that. And so I'll show you I'll walk you through a little bit on how you would actually do this in real life. Okay?
Great. Yeah.
So
perfect.
Let's see. I got to go share again.
Okay.
I'm not that smart, so I didn't know how to actually put my phone up on the screen and make it work during a Zoom call. So instead, I just took some screenshots of what the app looks like and a little of the reporting. So I'll kind of walk you through it. I hope this shows up well, but this is sort of the home page of my app. And you can see I've got different kinds of evaluations I can fill out. A daily evaluation, the EPAs. I can actually directly fill out a milestone if I want. We've got some OSCEs, procedural skills, and assessments. So let's go ahead and click on the EPA. So let's say I punch the button, I want to do an EPA. The next thing it's going to ask me is which resident do I want to work with? This is dummy data, so don't worry, there's nobody in here. The nice thing that we designed here was that it shows us the most recent ones that we've worked with. So I'm going to be working with the resident, you know, all day long and fill out multiple evaluations. So it's nice they're going to be in my recent list. Otherwise, everybody's down here alphabetically. I could hit this little search bar here and just type in the first few letters of their first name and be able to pull them up. So now I'm going to select a resident. So I just click on the resident that I want to work with. And here are the buckets that the EPAs are in. You know, adult OR cases, core activities, critical care, obstetrics. And also it shows me the most recent EPA that I filled out. So if that's one that I want to use, or if I want to break these out, and I'm just going to hit the compose button. But let's say I want to go here and I want to look at a little bit more. I clicked on core activity and it opened up, you know, one of these little things here. It opened up the other EPAs that I want to choose from. And the other way I can do it is I can type. So I hit the little search thing and I typed in out because I was doing an out of OR case, and you can see it brought up the out of OR perioperative case. And then I just would hit compose to go ahead and start my evaluation. Okay, so let's see if I've got one on right here. Okay, so once I've clicked on it and I said I want to do an evaluation on, and in this one I happen to be doing an adductor canal block. So I popped open, I said I want to do the evaluation, and I only have 3 things to fill out as a faculty member. So we went minimalist. Yeah. Okay, one of our theories at the very beginning of this project is if we can't get faculty to fill out 3 things on an evaluation, then we should just give up. because, there's no evaluation system that's going to work. What we need to do is we need to go to a system of professional evaluators. So, we have maybe just a few people in our department that are responsible for doing competency assessments because the general faculty just will not do it. So that was one of our theories, is let's go the absolute minimum. And we felt like the minimum that we could do was 3 things. So the first thing you have to fill out is difficulty. Well, and the reason we have this in here as simple or complex is because we know that one thoracotomy is not the same as another thoracotomy. It could be patient comorbid conditions, right? One patient is super sick, one patient is super healthy. It could be the complexity of the case itself, or it could be a complication. If they nick the pulmonary artery, that is a different thoracotomy than, a regular wedge resection in a 27-year-old. So to try and get at the things that distinguish that, we simply said, Gestalt, in your view, was this simple or complex? Similarly, if you're placing an A-line, there's a simple A-line with a big bounding pulse, and then there's that A-line with somebody that has peripheral vascular disease that, it's a Hail Mary, right? Even maybe with ultrasound. So that's this, simple or complex, to take that into account. The next thing I have to fill out is my level of entrustment. And then there's the little I that I can click to open up that page that shows the definitions if I forgot what they are. And then the last thing I do is I fill out comments. And actually the comments is pretty good. You can type if you want, but all you have to do is click the microphone button. There's a little microphone button you can't see on the screen here. And then you can dictate your comments in.
Oh, that's very cool. Yeah,
and actually it's really good. I was really surprised at some of the things that it was able to interpret when I've said in there, because I use it a lot. Like saying something like, I don't know, paraesophageal, and you think it would never get that word, and it gets a lot of them. So I'm kind of surprised about that. What we've instructed people to do in the comments is say, when you put this in, your feedback should be, well, why didn't you reach independent practice? Well, you remember when we did the preoperative evaluation and I asked you about what the echo results were and you didn't know what they were, or you didn't look up the prior spinal note to see that they tried 8 times and had to use the giant needle. So I would anyway, those are just examples of trying to explain in a preoperative evaluation why they didn't reach the level of independent practice. So that's what we've asked them to dictate in there. Now, practically speaking though, when I'm doing this, I actually do this with the resident. I say, well, what do you think? Cool. Was that a simple or a complex case? And we go over it together, we decide. I say, well, what level of trust do you think you need? What level of interaction do you think you need from me to do one of these? And then we have a back and forth about what we thought. Then this is when I would bring up the point about the spinal note, for example, or the other things. And then I fill out the comments right there with them. So that's my practice. I don't say everybody does that. But it takes me all of 2 minutes to do that, and I'm done.
Right. Very cool. Well, selfishly as program director, what do we or the CCC get to see on the back end from all this data that you're gathering?
Oh, great question. Okay, so I'm just going to click over here to right here. Now, I don't expect you to be able to see the detail. I just want you to be able to see that there's color bars and there's blue dots. All right.
Great.
So what we did in our group was we decided for every EPA, we decided what level of trust should you be able to achieve that would be your graduation target. Does that make sense?
Yep.
So for a complex neonatal case, maybe we don't expect you to get to independent practice. We only expect you to be reactive supervision. So we went through a process of also defining graduation targets for every procedure in every EPA. And then this is one of the reports that you're going to get. This is actually looking at the milestones, and these are all of the milestones that are automatically filled out by the EPAs. So you could look at each milestone. You could see the blue dot would represent whatever the graduation target was, and the green bar, the more green it is over here, represents what level of on the milestones that you were able to achieve. Right, so we were a level 5 on the achievement scale. So this particular one is a really good example. This is a report of what you would get at the CCC that would have been completely filled out by the EPAs. You didn't have to go in and fill out any other evaluations than just that. So one of the really interesting things is, there's a lot of milestones in here. This is dummy data on a resident that got independent practice on every EPA. And you can see they didn't get a bunch of milestones. And they're mostly in things like professionalism, practice-based learning, and communication. So I'm going to come back to that in a minute. But here's a good example. So this right here is the milestone for medical knowledge. And they got very low on medical knowledge. Now, how does that make any sense whatsoever if you are doing independent practice for thoracotomies? How can my medical knowledge be so crappy, right? That's because the way the milestones are written, you can't get to a level 2 or a level 1 milestone. It says, you know, based on your ITE score or what the CCC says about your training exam scores. That's how those milestones are awarded. This system could never do that, right? A workplace-based assessment has no role in deciding that specific milestone. Right. So that's why there's some gaps in here. So one of the projects that we had after we completed this part was, well, what other assessments do we need to fill in these milestones? Yeah. So I'm going to come back. So stay tuned on that. Cool. But I'm going to answer your other question about what the CCC gets. So the CCC gets a report like this, which is going to show their milestone evaluations. And actually, you know, what I can do is I'm going to stop sharing and I'm see if I can share a different screen for a moment.
Sure.
Let me just log in. I'm sorry, I should have done this in advance. I'd forgotten that I wanted to do this part. Okay, so now let me see if I can go back to sharing and all right, now do you see a different screen here now?
I do.
Okay, so this is what you do from an admin standpoint. So I would go over here to reports. I'm going to go to resident dashboards. I'm going to pick a particular resident. And what do we want to look at? Do we want to look at their EPAs, their milestones, their OSCE skills, procedural skills? So in this case, let's just look at their EPAs. So I'm going to knock this down here. And now I'm just looking at their EPAs. And this is the simple and this is the complex. So in a management of chronic pain patient, I can see the blue bars. You see the blue dots are all over the place because those are the graduation targets. I can see the number of evaluations they've gotten, and I can see what their current level of entrustment is. And if I want to click on any one of these, it will actually show me all the individual assessments graphed over time, what level of entrustment they were able to achieve. And then if I click on any individual assessment, it would actually open it up and I could see that assessment. I could see what they scored on that one. So this is what, what we've provided to the CCCs is you could look at this. You can sort by, I only want to look at the ones that I have achieved or the ones that I haven't achieved. You can look at procedural skills. You can see where they are, kind of like when I was in the Boy Scouts. I had little badges for all the things that I had, my fire making badge, my tent making badge, so we could see what procedures that they've gotten, and then we can look at the milestone mapping.
That's great. I can imagine you using this in real time in a CCC meeting to be able to say, hey, let's look at the real data and then inform our milestones rather than I think what many of us do, which is take some nebulous data and then make kind of gut feeling adjustments to it.
Yeah, exactly. That's exactly right. So when you got to the CCC, you might look at these, and if there was an outlier, like they're not meeting their graduation target for, general operating room case, what's going on there? Or right here, they're really low on PACU management, what's going on? Then you might want to open it and look at the comments and other things like that. But if everything is green, then you might not look at anything. And then you'd say, okay, we've looked at your EPAs and your procedures. And then you'd say, okay, well then let's look at, now let's look at your milestones. So then you could look at the milestones and see where they stand, and that would help you end up doing the scoring. But now comes the kicker, which is what we talked about was, wait a minute, what about all those ones here that we wanted to fill out? Yeah. So our committee went and said, okay, these are all the gaps that we have. So let's create a set of assessments that you can use to address those gaps. So I know this is a little tricky, but I'm going to go back here, and now I'm going to share again, and I'm going to do the PowerPoint because I had a slide in there where I've got that right here. So this is the list of things that our group came up with in sort of round 2, after we've had this system out there. By the way, I should point out that there are 8 programs around the country that are using this system now in our pilot phase. Yeah, so we've got 8 programs that have actually been piloting this for several months now. We've been collecting some data on how they're using it. But here's the new things that we're just coming out with actually now. They're coming out in the next month. We had 2 new EPAs, but this is one of them. So one, we created an EPA around leadership and managing a service or a team. Like when you're running the OR board, or you're in the ICU managing multiple patients, or you're managing the acute pain service, because this addresses several milestones around managing teams that weren't, that, of course, if I'm taking care of a thoracotomy, excuse me, that wouldn't be covered as a milestone. So this EPA is specifically designed when you're working with a resident that happens to be managing a service or a team, you can use this EPA. Similarly, there are some things that just may never come up, and you need to address them in SIM or something like that. Or, they might happen. Like I might have an adverse event that was significant enough that involved a medical error where we actually made a mistake and we had to disclose to the patient and all of that. But that may never happen to a resident. Right. So we had to have some things that we could do in SIM. So we created 5 OSCEs around an adverse event, patient conflict, conflict with staff, an ethical issue like a Jehovah's Witness, or an end-of-life decision, and then dealing with physician impairment. And so if you do these OSCEs, then you will also end up filling out a bunch of other milestones on the back end. And then we had 7 special assessments that could be used on an ad hoc basis. These are likely to come up with your resident. They will come up. You just need to fire this special assessment up when you happen to run into that circumstance. So like you're working with them on a QI initiative. You're reviewing personal outcome data with them. This is for a program director. You're working with them on their individual learning plan. They're developing it or they're modifying it. Teaching others, demonstration of wellness behavior. So our goal was, if we implement these assessments along with the EPAs, we now have a programmatic system that will cover all of the EPAs. So just as an example, this is what the special assessments look like on the app. I can just pick one of the assessments right on here. I hit compose, and then it will ask me a few things. So I'm receiving feedback. They accepted constructive feedback with minimal resistance, successful, or failed to demonstrate. They accepted the feedback and incorporated it into their practice. These are just yes, no things that I can click through. And on the back end, it's filling out milestones for me.
That's really neat.
Okay, well, that's a lot of talking there. Sorry about that.
No,
okay.
I think that's really exciting. A couple follow-up questions. So my DIO really wants us to keep all of our assessments within MedHub, and I know other people use New Innovations and other products. So what, in developing this technology, how did you think about integrating it into other systems?
Yeah, that's another really good question. So we do, of course, I'm not responsible for that. We asked the company, we told them exactly that everybody has all these other systems, and they're often mandated by the university, right? It's not an individual department decision. Like I can't decide to use something, but they require us to use MedHub. So in fact, we use MedHub at our place. So they have written the ability to export data from this system into MedHub. Not New Innovations that I know of, but they've done it with MedHub. Yeah. The thing about it though is, even though it can do it, it doesn't look very good. When you look at the data in MedHub, it's this just giant files of information. And, they don't have that reporting like I showed you, right? MedHub doesn't have that style of reporting that I just showed you, which would be so easy to help me fill out the milestones at the CCC, or even make a CCC decision, right?
Right.
MedHub doesn't have anything like that. So it took the information and turned it into something that was less valuable in MedHub. So it does it, and it satisfies the requirement that it's in MedHub, but we can still use the reporting on this end of the system to do our decision making and fill out our ACGME milestones. So it's not great. But that also, because it requires MedHub or New Innovations to cooperate with what might be a competitor. So I don't know, how well they'll be able to do that.
Right. Have you gotten any sense from the residents or the trainees on their side, how they view the feedback that they're getting in response to this?
Yeah, that's a good question. We did a survey in the pilot data after we were running the pilot. It was at end of month 2 or the end of month 3. We ran a survey, and unfortunately, I don't have the results right in front of me. But we were able to show that first of all, the feedback was much more timely. So that it was coming right at the time of when they were doing the case, because that was the way we rolled it out to everybody. We said, this is so easy, you can do it in 2 minutes. You should do it at the end of every single case, right?
Yeah.
And so they did think that was more timely. I think it was also they were getting a lot more feedback, so that they were getting more frequent feedback. It was successful on that point. I don't know that the feedback was necessarily any better. I don't think that it showed a statistical significance that they thought the feedback was more and somehow more helpful to them.
Right.
But it was more timely and it was more frequent.
Oh, that's great. I was thinking about it as you were introducing the EPAs. We struggle sometimes with our residents adopting what you could call kind of a performance mentality in residency, where they, and this happens, I think, worse when you want to work with a program director, where they, oh, I'm going to intubate with the Mac 3 because I'm comfortable with the Mac 3 and I'm going to do well with the Mac 3. And I'm not going to use the Miller blade because I'm not as good with the Miller blade. And we, of course, as educators, want them to use the Miller blade because we want to see them struggle and help them to the next step. How do you think EPAs play into that? Do you worry at all that like the kind of paradigm of trust pushes people towards performing and not learning? And if so, are there ways that we can, as educators, kind of push them back in the other direction? Or does it not really matter because they're going to feel that pressure regardless of what scale we're evaluating them on?
Well, I wish I had a great answer to that. I will say on the procedural skills, though, it's a nice way for them to know what they need to work on, and then they can try. But we don't have one separate for Miller and Mac. Right. But I haven't done any ultrasound guided A lines. I need to work on that. So it shows them the number of evaluations that they have and also where their assessments, so they can try to work on procedural skills. I don't think probably there's no way to get around it on doing a case for a thoracotomy. I don't think it would have this performance anxiety part of it. But I do think what you brought out is a really, really important point. And I'm a big believer of, we have to, and we don't do a good job of it, I'm going to admit it. We have to do a better job. And when our residents first come to us about discussing to them about, the feedback alliance, that it really is, that it's coaching, and that, you should not be afraid to show, exactly what you've said. I'm only going to do, if I give a resident a choice between, we're on the block service because I'm a regional attending. Hey, I've got two things to do. The fellow can do one, you can do other. Do you want to do this block or you don't want to do the epidural? And they'll say, oh, I'll do the epidural so that they can look good, right? Exactly like what you said. And so how do we do that? And I think that, again, is a cultural thing that we need to instill in the trainees and the faculty about how we do feedback. It's kind of that, the growth mindset. You probably, heard that kind of concept. I think it's really related to setting a growth mindset in our trainees and the faculty.
Yeah, I have to say, I love the idea that you brought up of, with a simplified metric of being able to do it right in front of the resident and open that door to let's discuss it together in real time. And I think that's probably one way, at least I could envision of breaking that down, because this isn't, hey, I'm going back to my office to write something bad about you into the computer system. It is, no, we're having an active discussion about how you can get better. And that's what I really care about. And I'm showing you that I care about it by working on this right here with you, which I think that's a really neat tool. And that is so much harder to do when you have one of these nebulous evaluations that, where I have to squint over the scale every time to figure out what I want to score somebody.
Yeah, I wasn't even aware of what I was going to be evaluating them on until afterwards, right?
Right.
So how could I have had that conversation with the trainee? Yeah, exactly. Yeah, so I try to make it collaborative in producing the evaluation. There's no surprises. And sometimes I even tell them, hey, I'm going to comment about this, and that'll just serve as a reminder to you to remember next time to try and do the thing, right?
Yeah.
So it was more of a reminder to them as opposed to, so kind of look at it. So they have got similar reports that they can look up and see the same stuff that you and I could see, or the administrators could see on the system.
That's great. What do you think are some controversies or future directions that you'd like to see this project continue into?
Well, I think the first thing is which I was really appreciative that we could do in an interview, because I don't really have a way of we've done this work that I think is important, and we're finding it fairly easy to adopt. If you as a program director wanted to do this today, you could simply call up the company and turn on a light switch, and you would have access to all of the EPAs, the procedural skills, all of the forms that we've built, all of the new special assessment forms that we built, it's done. You wouldn't have to do anything. If you wanted to, you can go in there and mess with it, make your own, you could screw with it. But generally we don't have a lot of time. And so being able to do something out of the box is quite helpful. So that's I think where I'd like to see this go, is somehow we got to get the message out there to people that there is this tool that you can use, and at least the preliminary data is showing that it looks good, which means we have a challenge, right? We've got to do some studies to try and prove that this system has some sort of validity, is that the feedback, as you mentioned, is it of better quality, timeliness, effectiveness? Are the EPAs a valid mechanism? We've just made up the mapping of the EPAs to the milestones. I will point out, though, they just made up the milestones. So, so I think there's some future directions that we need to go, and it's going to be really interesting to see how the new assessments are being used. I'm really going to be curious to see, because literally they're just going to be coming out in the next month. And it'll be really curious to see how people use them. One of the things we have looked at, though, is we've looked at the number of evaluations that people will fill out. And we found if you compare the number of evaluations compared to whatever system they were using before, doesn't matter. We just asked to count how many faculty evaluations got submitted, or ignored, right? Yeah. Versus this system. And it's probably, triple or more, a vast difference in the number of assessments that are being filed. So that doesn't mean they're better, but at least we tell the residents it's more. Now, the other future direction is culture change, right? Even during the implementation period. Now, we couldn't just throw away the old system because we were using something new. We had to keep them both around. So even with that, it would have been much easier if it just mandated, right? We're turning off the old system. You have to do this. The department program director says you have to. Done. Chair says you have to. We didn't do that because it was something new and piloty. Now we hope that we are to the point where we've developed enough of the technology and the things that you could actually turn off the other assessments. It'll still feed your system, but you don't have to do those other evaluations that you're doing.
Oh, that's great. Well, that was really my final question, is if I wanted to start using EPAs today, what advice would you give me about that process?
Yeah, and so you can develop your own EPAs if you want. We are attempting to publish a paper on it. Unfortunately, just got rejected, so we're working on a revision. Basically, they liked the paper. What they didn't like was that we didn't put any of the pilot data in. And we were hoping actually to publish a second paper on one on the process of developing it, and then one on the pilot data. But I think we're going to have to mash them together, and hopefully we'll get that. But it's a long publication period. You probably wouldn't maybe see it for 6 months or a year, even if we're successful in getting it published. But if you wanted to use it today, you could turn it on, and like I said, you could mess with it all you wanted to, or you could just use the stuff we've developed. You could take some of the things that we've developed and say you like it and get rid of the other things. So you would have that option. I don't want it to make it sound like it's a commercial endorsement. So I wasn't sure if I should even mention the name of the company that we worked with to develop all of this.
Sure.
I don't know. Well, should I or no? That's what I thought. If anybody's interested, they can send me an email and I can point them to the company. We have no financial interest in it. We don't get a penny for it. We did all of this work. We just needed somebody to do technology, but we did all the work part of it. And we have no interest. Nobody that has anything to do with that other company at all, with one exception. And that is anybody that's a Toolbox member gets a discount, because we did a lot of work for them and they can go use this for any anesthesia program they want to sell it to. And we said, well, can you just give the Toolbox people a discount? That's all. So that's the only thing that there's anything in it.
That's great. Well, I want to congratulate you on all of this impressive work. I think assessment is something that all of us really struggle with, and it's exciting to see a new, simplified, and kind of technologically savvy solution to it. So thank you for the chat today. I really appreciate it.
Well, thanks so much for your time. I appreciate the opportunity. Obviously, I'm super passionate and excited about this project. It's been a really great project to work on. And this is a great venue to share it, with the other educators in the Society for Education in Anesthesia. I hope you guys find this valuable. I think one of our roles at the SCA is to try to bring out things that, we can all try to learn from or maybe implement in our program. So thank you so much.
Great. Thanks, Glenn.
All right. Thank you.